morning, everyone. Thank you so much for having me. My name is Jessie Wang, and I'm a glaucoma fellow at the Duke Eye Center. So I'm here with Dr. Leon Herndon and then my co-fellow Lucy as well. I'm just going to wait for them to pull up my slides. Alrighty, okay. Um, okay, so we can go on to the next slide. And I have no financial disclosures. Next slide. So just briefly, an introduction and history of gonioscopy. So the two fathers of gonioscopy, it was founded by Dr. Trantas and Dr. Salzman. So Dr. Trantas, he used a direct ophthalmoscope. Is this one working? Okay, so he used a direct ophthalmoscope and simultaneous limbal digital pressure. The word gonioscopy is described from gonia, meaning angle, and then scopian, meaning observe. So the basics of how gonioscopy works is that due to total internal reflection at the tear-air interface, a lens is required to allow light to pass through the interface and bounce off a mirror into the examiner's eye. So there are two different types of gonioscopies. So direct is what we use in the operating room. So, with direct lenses, you do not need a mirror, but the disadvantage is that the patient needs to be supine, which works in the operating room, but not in clinic. And it's easy to use. Other than that, allows us to do MIGs. So an indirect gonioscopy is what we use in clinic. And so there are multiple types. Some require a goniosolve, others do not. But in these, the patient has to sit upright. Okay, so the actual procedure of a gonioscopy in clinic. So first, the patient should be behind the slit lamp. And then we use topical anesthetic to make sure the patient is comfortable. And what I found is easy is that you ask the patient to look up, you gently use your finger to pull the lower eyelid down, and then you place the lens on the cornea. And then through each of the mirrors, usually there are four, we can view the angle. And the quadrant of the angle that you're viewing is actually 180 degrees away from the mirror that you're using. So if you're looking through the superior mirror, you're looking at the inferior angle. So, there are different ways to classify and grade, your gonioscopy exam. There's a Shea, there's a Schaefer, but I won't go into them. What I usually do is I just document what I see. So first I document the width. So is it narrow? Is there no angle structure or apigmented TM, or maybe it's open and you see scleral spur. And then the next is I comment on the pigmentation. So is it even, is it patchy? And then, most people, usually it's about a 2+ pigment, but for example, pigment dispersion syndrome, you'll see increased pigment in the inferior angle. So that's important to note. And then the last thing is I, know either the presence or absence of any other structure. So for example, PAS, NVA, or angle recession. And then so indentation gonioscopy is a variant of gonioscopy. Essentially, it's used to differentiate between oppositional versus synechial angle closure. And so, for example, as you apply pressure to the cornea, you're able to see, is there scar tissue, and that's why you can't see the wider angle structures, or is it narrower, but is able to be indented to a wider view. And then the surgical application is that, a pre-op gonioscopy is important because it determines if we're able to actually do our MIG surgery. So in areas where there's focal PAS, you have to pivot to a different quadrant or a different clock hour to do your MIGs. And then if it's, yeah. Okay, so tips for success. So the first thing is that if the patient's comfortable, it makes your exam a lot easier. A second thing that I found is that if you press with your lens too hard, you're going to get corneal striae, and that's going to obstruct your view. It's helpful to center your lens, and you can also oftentimes tilt the lens to get the optimal view of the angle. Using a short, thin beam in the clinic is helpful to not distort the angle anatomy. And then in the OR, if you do MIG MIGS, you can do it either before or after surgery. Oftentimes, if you do the MIGS after surgery, the angle is, or after cataract surgery, the angle is wider, so you get more space. And then also, if you don't have any stain like, vision or trypan blue, after surgery, oftentimes you can see blood in Schlemm's canal from the reflux of blood during the pressure differential during cataract surgery, and that can help you orient. And that is it, I think. Okay. Yep. Oh, I have 2 more minutes. Okay. Sorry. I wasn't sure if that was time's up. Okay. Okay. And then for my next few slides, I actually just have a couple examples. So here we have angle recession. So you have a widened ciliary body band. Here we have a cyclodialysis cleft. Pigment dispersion syndrome, I said you have increased pigment in the inferior TM classically. And then neovascularization of the angle, you have these fine blood vessels that cross the trabecular meshwork. And then finally, these are spots of peripheral anterior synechiae and blood in Schlemm's canal. So that is it. That's all I have.